Okay, so we're going to move on. We're going to be talking about some conditions that affect the release of antidiuretic hormones. So these are conditions that are relevant to the relationship between the hypothalamus and the posterior pituitary. Okay. So we're going to talk about two very opposite conditions that affect secretion of antidiuretic hormone. The first is a condition that overproduces antidiuretic hormone, and the second results in an undersecretion. So the first one is called the syndrome of inappropriate ADH secretion, or SIADH. The reason why we call it inappropriate is because release of ADH is supposed to be connected to our plasma osmolarity. And so in SIADH, we have much more ADH release that is appropriate for our plasma osmolarity. Okay. Now, when that happens, what it does is cause our plasma osmolarity to go down, right? ADH, antidiuretic hormone, diuresis is the excretion of water. ADH is going to cause us to retain water. That retention of water will dilute our blood and cause a hypoosmolar state. So there are many different causes of SIADH. So different categories include, number one, we could have problems that are related to increased hypothalamic production of ADH. So that includes things like infections of the central nervous system. So that can be an meningitis or encephalitis, and it can lead to the hypothalamus to simply produce more ADH. Neoplasms, so we have these either benign or malignant tumors that are going to overproduce ADH. And then we have certain medications that actually increase the hypothalamic production. So certain chemotherapeutic drugs, certain antipsychotic drugs, they cause the hypothalamus to overproduce ADH. Pulmonary diseases. Interestingly, with certain types of pulmonary disorders, like pneumonia and tuberculosis, acute respiratory failure, and sometimes even asthma, what we end up with is too much ADH production. Now, the sort of purpose of this or the mechanism is not entirely understood, but one theory is that when we have these pulmonary diseases, it can lead to hypoxia or hypoxemia, where we don't have enough oxygen in our the oxygen carrying capacity of our blood goes down, right? Because there's less gas exchange or there's less ventilation of the lungs. And so one compensatory response to that could be to simply expand plasma volume, right? So sort of as an attempt to expand blood volume. So that's one theory behind why with some pulmonary diseases like pneumonia, tuberculosis, acute respiratory failure, asthma, we can end up with this overproduction of ADH and this hypoosmolar state. We also see SIADH sometimes with severe nausea or severe pain. Okay? Now, we also see this sometimes with severe nausea, severe pain, traumatic injury, surgeries. So this is related to this activation of our stress response. So when we have a strong activation of our stress response, we stimulate the sympathetic nervous system, and the sympathetic nervous system does innervate or connect to our hypothalamic control of ADH secretion. So whenever we have a really strong activation of the stress response, we're going to have release of ADH. And so in severe nausea or pain or traumatic injury, we can end up with that as well. We also see sometimes ectopic productions of ADH. So this is where, when we studied the different cancer types in previous sections, we did study how certain cancers produce hormones. And this is particularly true for certain lung cancers. So when we see small cell or oat cell carcinomas of the lungs, bronchogenic carcinomas, carcinomas of the duodenum as well. They can produce various hormones, including ADH. So sometimes certain cancers can overproduce ADH, leading to SIADH. We also have certain drugs that can potentiate the effects of ADH. So in that case, we don't actually have excess ADH, but we have drugs that can mimic the effects of ADH, and so the person presents with a syndrome similar to SIADH. And then we just have sort of good old idiopathic, right? Sometimes we see somebody with SIADH, they don't conform to any of the causes that we understand, and so we don't understand why, but we do know that they are overproducing ADH and it's causing hypoosmolarity. So what do we see? What are the clinical manifestations with SIADH? Well, so what we see is serum blood hypoosmolarity. People's blood osmolarity is going to go down, and we're also going to see hyponatremia. So that excessive water is going to dilute our solutes, including sodium, leading to that hypoosmolarity and hyponatremia. We are also going to conversely urine hyperosmolarity. Now, these two together are a hallmark sign for some sort of ADH problem. Anytime blood osmolarity does not match urine osmolarity, you know ADH is wrong. Okay? Because your body, if ADH secretion is appropriate, your blood osmolarity should match your urine osmolarity. But if they're going in opposite directions, you know ADH levels are off. Okay? And if they are off in the direction of too much ADH, you will have blood hypoosmolarity and urine hyperosmolarity. The rest of these clinical manifestations are just ruling out any other cause. So if you have these first two, blood hypoosmolarity, hyponatremia, and urine hyperosmolarity, then you might have SIADH if your urine sodium excretion matches your sodium intake, if you have normal adrenal and thyroid function, and if you don't have any conditions that can alter volume status, like congestive heart failure or renal insufficiency. In the absence of these 3 through 5, right, or I should say under those conditions 3 through 5, these 1 and 2 is enough to really suggest that you have SIADH. The second condition is the opposite situation. In diabetes insipidus, we now have a condition where either you are not producing ADH or your kidneys cannot respond to ADH. And so the net effect is basically hyposecretion. So diabetes insipidus, so this is interesting, right? We think about the word diabetes as being a blood sugar problem, right? But in fact, the word diabetes is derived from the Greek word, it's a verb called diabeinin, which means to stand with legs apart as if in urination. And it harkens to this symptom that we see with people, that the Greeks saw with people, that sometimes people had excessive urination, right? We call that polyuria. Now, we know that in diabetes mellitus, we have polyuria because their blood sugar levels are too high, sugar spills into their urine, right? And it causes an osmotic diuresis. With diabetes insipidus, we also are going to have polyuria, but it has nothing to do with blood sugar. What it's going to have to do with is the fact that we aren't either are producing ADH or not responding to it, and so we cannot retain water. So all of that water ends up in our urine, and we have polyuria. So diabetes, the term diabetes refers to that polyuria. Now the word insipidus comes from a Latin word which means without taste. And so this is a bit of disgusting history, but way back when, before like we had LabCorp or Quest, urinalysis, there's a long ancient history of urinalysis, and part of urinalysis used to be to taste the urine sample, because if you had polyuria and you tasted the urine sample and it tasted sweet, then that was diabetes mellitus, right? Or mellitus, because mellitus means sweet. But if you tasted the urine and it had no taste, right, it was just mostly water, then it was insipidus without taste, and it was diabetes insipidus. Because the urine of people with diabetes insipidus will be mostly water, because they cannot retain that water. It all ends up in the urine. So there are two forms of diabetes insipidus. We have what's called central DI, or central diabetes insipidus, and that is a failure to secrete. Central meaning central nervous system. Your brain is not producing ADH. And then we also have something called nephrogenic DI. And nephrogenic DI refers to nephro meaning kidneys. This is where you're producing ADH, but your kidneys are not responding to it. Okay? So it's really a ADH receptor problem at the level of the kidneys. So people with diabetes insipidus, they are going to have excretion of large volumes of very dilute urine. Okay? They have either a partial or a completely total inability to concentrate their urine. Urine output is going to be tremendous. It can be anywhere from 4 to 8 liters a day or 8 to 12 liters a day. Just think about that, right? You have 5 liters of blood in your body. So you're talking 4 to 8 liters a day or 8 to 12 liters a day. And so one of the other hallmark signs of diabetes insipidus is polydipsia, which is an extreme thirst. And diabetes mellitus folks are also going to have polydipsia, because both of these groups are going to be very dehydrated. Right? So you've got somebody who's drinking constantly because they're terribly thirsty. They're urinating anywhere from 4 to 8 liters a day, 8 to 12 liters a day, and it's because their bodies just cannot retain any of that water. So that all of that drinking does not improve their hydration status. So causes. We have genetic causes of DI and non-genetic causes. By far the most common form of diabetes insipidus is central DI, and the most common cause of that is going to be traumatic injury. So most people with diabetes insipidus, they sustain some sort of head injury, or maybe they had a tumor, or maybe they had a neurosurgical procedure, but there was something that caused some sort of traumatic injury to the hypothalamus. We also have destructive lesions of the pituitary or hypothalamus. So all of these are the most common causes of diabetes insipidus, and it's going to cause central diabetes insipidus. Less common are genetic causes. So, and we have genetic causes of central DI, and we have genetic causes of nephrogenic DI. Right? So, and there are autosomal dominant patterns. There's an autosomal dominant central DI. We have autosomal dominant nephrogenic DI. Now, one that's actually got an interesting history to it is this one with an X-linked nephrogenic DI. Right? So X-linked, we've talked about this before, where females have 2 X chromosomes, males only have 1. This is a recessive. When it's an X-linked, it's usually a recessive trait. So if you have a female with 2 X chromosomes carrying 1 recessive, that trait is not going to, they're not going to be affected by the disease because they have another X chromosome. But if you have a male, that's the only X chromosome they have, and so their X-linked disorders are going to affect men more than they're going to affect women. And so there is this old folk tale in Irish history that this there is a disease that affects mostly boys, that causes extreme thirst and dehydration, and that it's actually somewhat of an offensive story, but the legend is that there was a gypsy who had a very thirsty son, and she was going door to door through Ireland, trying to get someone to offer to give some water for her thirsty son, and nobody would give her any. And so she put a curse on the entire island, that all of that boys will carry forward this, or boys will be affected. The mothers will carry this disease to their sons of extreme and unquenchable thirst. Right? And so that's the folklore behind this X-linked nephrogenic DI. So interesting story, but obviously not true. Okay, so what do we see in terms of lab values? What do we see as clinical manifestations for diabetes insipidus? As I said, we're going to see blood osmolarity that doesn't match urine osmolarity, right? And if we look at the actual value versus normal and with diabetes insipidus, if we look at ADH concentration, so in central DI, it's going to be decreased, right? It may be actually 0. With nephrogenic DI, it's going to be either normal or high, right? Because you're very dehydrated, you're going to be producing lots of ADH, but it won't help because your kidneys are not responding. Serum osmolarity. Serum osmolarity is going to be very high. Okay. Serum osmolarity is going to be high because you are not able to retain any water. So you're going to have hyperosmolar blood. Serum sodium is also going to be high because you lack that water. Urine osmolarity is going to be very low. So there's that mismatch, right? High blood osmolarity, low urine osmolarity. Hallmark sign for not enough ADH. Okay. Urine output is going to be extremely high. Okay. And then fluid intake is also going to be extremely high. That polydipsia. This over here, they mentioned something called psychogenic DI. Psychogenic DI is an observation that sometimes people with psychiatric conditions, especially people in acute psychosis, will have this extreme thirst. And sometimes that is labeled as psychogenic DI. So they are presenting a little like, at first glance, somebody with diabetes insipidus. Where they are extremely thirsty, they're urinating a lot, but if you looked at their blood levels, if you looked at their lab values, their blood osmolarity will be low, right, because they're drinking so much water, and their urine osmolarity will be extremely low because they're trying to urinate out all of that water. So somebody with psychogenic DI, just that psychiatric polydipsia, they are going to their urine is going to match their blood, okay? But they're going to, just in terms of their how they present, they're going to have that polydipsia, that drinking a lot, that weird thirst, very extreme thirst, and also that polyuria. Okay? But their blood values are going to match their urine values, so they don't have DI. Now, in terms of treatment, central diabetes insipidus is easier to treat because you just have to give basically supplemental ADH. There's a drug called desmopressin it's a synthetic ADH. It will manage the disease just fine. Nephrogenic DI is harder to treat because you can't really give desmopressin. The body can't respond, the kidneys can't respond to ADH. It's not going to respond to desmopressin. So there is a paradoxical treatment with nephrogenic DI. It's basically treated using thiazide diuretics. And so that hopefully doesn't make sense to you because diuretics are used to promote water loss, right? So somebody with nephrogenic DI, their problem is too much water loss. But interestingly, somebody who has nephrogenic DI and takes a thiazide diuretic, there is a paradoxical effect of actually enhancing water reabsorption at a part of the nephron that it doesn't usually happen at. So, so people with nephrogenic DI have this paradoxical response to this thiazide diuretic.